Thank you very much. One of the pleasures of being the president-elect is I get to introduce our president. Dr. David J. Sugarbaker is the 94th president of the American Association of Thoracic Surgery. If I could have the first slide, please. He was born in Jefferson City, Cole County, Missouri. And as a child, he grew up in an apple orchard, which is what's shown here in an aerial view of his family home. From a very young age, David acquired a love for the outdoors early on, and this love has persisted throughout his adult life. His mother, Geneva, was a nurse, and his father, Everett D., was a surgical oncologist with a very busy practice in Missouri. He came from a large family, as you can see. David was the 8th child of a family of 10 children. And by the time of his birth, his father was already a well-established oncology surgeon in practice in Missouri. As the son of a surgeon, Dr. Sugarbaker was exposed to unique insights, practical skills, and valuable opportunities in the world of surgery from a very young age. He remembers fondly assisting his father in the operating room, the clinic, and in research pursuits in tumor biology. Aside from teaching him the basic principles of surgery, his father provided critical mentorship about not only how to approach his career, but later in life how to approach his surgical practice, how to establish a new surgical division, which his father had done. David also inherited his can-do approach from his father and from both of his parents. His can-do approach to the world that prepared him for later in life, no matter how minor the tasks or how complex the work, or even how simple, including yard work. He also developed his take-charge attitude, where no task was too complex or too demanding, but I dare say he also found some of these tasks downright enjoyable. David had many hobbies which he started at a young age. Throughout his life, he has had a passion and an interest in collecting clocks. His interest in sports and sports activities in high school led him to the world of wrestling. And I dare say those skills came in handy as later in life when he was developing his thoracic surgery program at the Brigham Hospital. Sugarbaker attended Wheaton College in Illinois, where he studied biology and philosophy, an interesting combination, although I'm sure that also came in very handy later in life. And then, of course, he went on to attend medical school at the Cornell University Medical College in New York City. He graduated at the top of his class as a member of Alpha Omega Alpha and was inspired to pursue a career in surgery by his father and his two older brothers, which are shown here on the picture on the right, Everett V. and Paul, who also became prominent surgeons in their own right. In fact, one could say that medicine ran in the Sugarbaker blood. Not shown here is David's sister, Elizabeth, who's also a prominent pediatrician. It was at this time that David met Linda Stirk, who was to become his wife of 35 years. Here on the right is David showing Linda some of the traditions of Missouri, including the art of managing a mule pack. I'm sure that skill came in handy for both of them later on. In 1979, 2 weeks before starting his surgical internship, David and Linda married, and together they raised a family of 6 children. As a young father, David continued in his father's tradition of self-sufficiency and including his children in all aspects of his life, whether it was building a deck, putting together a swing set, or using a riding tractor to work in the yard. During this early period in his residency, despite the demanding schedule, David spent as much time as he could with his family, and of course, some of this time was spent catching up on badly needed sleep. And in some cases, his children contributed, as you can see in the picture on the left, by reading their father to sleep. David was always an efficient father. When he was assigned the task of washing the children, he did this in a very efficient manner. Rather than doing one by one, he felt that doing them all together was much more effective. Well, Dr. John Manick, who I believe is in the audience, selected him for a general surgical residency at the Peter-Ben Brigham Hospital in Boston. His interest in thoracic surgery began during his 2-year research stint at Harvard Medical School's Thorndike Laboratory, where he studied benign esophageal disease. In 1986, he completed his surgical residency at the Peter-Ben Brigham Hospital in Boston after completing a year as chief resident in general surgery. And surveying the field at that time, he noted that many leaders in esophageal surgery were trained in cardiothoracic surgery. Dr. Manick gave him encouragement to pursue his career in general thoracic surgery training at the Toronto General Hospital, which at that time was one of the only general thoracic training programs in the world. He was privileged to train under Drs. Griffith Pearson, who was the program director at that point, but he also trained with individuals who I'm sure you'll recognize: Dr. Joel Cooper, a past president of our society or association, Alec Patterson, also a past president of our association, and of course, the late Robert Ginsburg. He completed 2-year residency as both a chief resident in thoracic surgery and cardiac surgery under Ronald Baird, who was the chief of cardiac at Toronto General Hospital at the time. At the age of 35, he was appointed chief of the newly formed Division of Thoracic Surgery at the Brigham and Women's Hospital. Dr. Manick demonstrated tremendous foresight in the field by establishing the first general thoracic surgery division and training program in the United States at the Brigham and Women's Hospital. He showed great faith in his trainee by personally seeking support from the Brigham and from Harvard Medical School to appoint Dr. Sugarbaker chief of this new division of thoracic surgery. Here, David is shown with some of his colleagues at the time. I'm sure some of you will recognize Dr. Mac DeCamp and Dr. Steve Menser, and two young fellows at the time, Dr. Scott Swanson and a very young David Adams. Dr. Sugarbaker's rise to prominence in the specialty of general thoracic surgery and his academic accomplishments in the field can be attributed both to his own personal drive, but I think also to his support by his mentors. Here we're showing 3 of the most important individuals who helped him through his career. To his left is Dr. Griffith Pearson. In the center is Dr. Manick, and of course, Dr. Hal Urschel. Following in his mentor's footsteps and in his view that anything can be accomplished if there is focused dedication and unity of purpose, a theme that you'll hear over again, the thoracic program at the Brigham and Women's Hospital thrived under his leadership, as demonstrated by the growth of the program, not only in volume and numbers, but also in depth. As the chief of the Division of Thoracic Surgery at Brigham and Women's since 1988, he focused on not only building one of the top thoracic surgery programs, but perhaps his greatest legacy, like that of his mentor Pearson, are his trainees, which now, in Dr. Sugarbaker's case, some over 80 from all parts of the globe. Many, if not most, of these individuals have gone on to their own successful careers throughout the world. And finally, as accomplished as David has been in his professional career, it is also important to note that he has dedicated as much, if not more, energy to his family. Here shown in a recent photograph with his wife, Linda, and his 6 children, Deborah, Peter, Nathaniel, Everett, David and his fiancée, Julie, and Rena and her husband, Adam, and last but not least, their granddaughter, Anika. Ladies and gentlemen, please join me in welcoming our president, Dr. David J. Sugarbaker.
Thank you, Pedro, for your kind words and gracious introduction. Members and guests of the American Association for Thoracic Surgery, it has been my privilege to serve as your 94th president. During my years of service, the purpose of the AATS has always been crystal clear: to promote excellence in thoracic surgery. In keeping with tradition, I'd like to begin this address by acknowledging those who have had a major impact on my career in surgery and on my life. My mother, Geneva Van Dyke, was born in 1911, and my father, Everett Sugarbaker, born in 1910, they were both of Dutch descent, were married shortly after these pictures were taken to begin their life's adventure together, and I'm glad that they did. This is a photo of my mother that appeared in Life magazine in 1954. She was a passionate advocate for children. She was president of the school board for 20 years and president of the park board for 15 years in our hometown of Jefferson City, Missouri. She is currently 103 years of age and remains an inspiration to all of her children, grandchildren, and great-grandchildren. Mother would always tell me, just be yourself, David. Everybody else is taken. Here are the Sugarbakers of Milton, Massachusetts. Well, the scriptures say that children are like arrows in the quiver. It's true. And I'd like to take this opportunity to thank them as we continue to travel this life together. But tempus fugit. Life continues to bring new joy with each passing day. Here's our family now with 3 new additions, and as Pedro just mentioned, the additions: Dave's fiance, Julie, Rena's husband, Adam, and our first grandchild, Annika, the little Dutch princess. My beautiful wife, Linda, went back to school last year and received her nurse practitioner degree. She is a living example of eternal youth. Linda, I remain grateful to you for all of your loving support and care, advice and guidance to all of us in the family. You've always been there for us with inspiring words and loving kindness through all the challenges and victories of life. Linda and I were married in 1979, and 2 weeks later, I started my residency at the Brigham. Every day at the Brigham yielded new bits of wisdom, little technical tricks, a new knot to tie, an interesting case. It wasn't so much all the time we spent in the hospital that made it so much fun. It was the intense desire to learn that we all shared. This is my group of residents at the Brigham. Little did I know that 3 of my future partners were in the crowd: Scott Swanson, Rafael Bueno, and Mac DeCamp. My mentorship in surgery began very early in life. My dad had clarity of purpose and focused attention. He absolutely loved what he did. He loved his patients, and they loved him. His life was a grand example of living life to the fullest in every respect. His example inspired me. After his retirement, he loved to visit me at the Brigham to discuss and observe surgery. His advice, counsel, and strong, loving support were constant. I remember calling him to report the birth of our 5th child, Nathaniel, who's here today. His response over the phone was, "David, 5 children. What a great start." He loved to talk about surgery, any aspect of it, from instruments to pathology to tumor biology. We're honored to have Dr. and Mrs. John Manick here with us today. What do you say about a man to whom you owe your career? John Manick was Surgeon-in-Chief at the Brigham and the Moseley Professor of Surgery at Harvard when I arrived. He trained me as an academic surgeon. He had the vision and foresight to establish the first dedicated division of thoracic surgery in the United States. And I can say that I've learned from Dr. Manick that the most important quality that your mentor can possess is that he or she believes in you. The most influential mentor is one who believes in you through mistakes and missteps, seeing them as lessons learned. One who continues to give you confidence in who you are and what your purpose is. One who helps you to keep your eye on the ball. Thank you, Dr. Manick. Dr. Eugene Brunwald has been a mentor and friend for 35 years. His example is one of integrity and wisdom. His direction has always been sure and his support unwavering throughout my career in surgery. Dr. Joseph Murray is seen here in Stockholm in 1990 receiving the Nobel Prize in Medicine for performing the world's first successful human transplant at the Peter Bent Brigham in 1954. Joe showed me how focus and creativity could solve even the most complex problems. Dr. John J. Collins, Jr. trained under Dwight Harkin. He was chief of cardiothoracic surgery when I arrived at the Brigham. Jack was a true gentleman. He loved to teach and saw each resident as his legacy. Well, I first met Larry Cohen as a junior resident. Larry was a fire-breathing, new young attending. I was awestruck by his technical ability, clinical insights, and tremendous sense of humor. And little did I know then that Larry would have such a profound impact on my career. Larry and Roberta, thank you very much for your friendship and for your support. Griff Pearson is known to the world as the father of thoracic surgery. He is seen here during his fellowship with Mr. Belsey. From the day that I entered the Toronto General Hospital for my thoracic training until this very moment, Griff Pearson has been a close friend and mentor. He showed me how to build a team, how to organize a service, and how to recruit highly talented staff, always in his relentless pursuit of excellence. And here's the staff of the Toronto General Hospital in 1988 that trained me. Imagine that. Three of these have been presidents of the American Association of Thoracic Surgery. Joe Cooper was division chief at the time and was a fount of ideas. His passion for the game was infectious. Alec Patterson was the resident's confidant and kept me out of trouble most of the time. He's the consummate teacher, researcher, clinical surgeon, and true leader in our field. And during our 2 years in Toronto, Susan and Alec were very generous. Linda, the kids, and I almost lived at their house. I spent 6 months at the TGH and 6 months at the Mount Sinai Hospital. The staff at the Mount Sinai at that time were Bob Ginsberg, seen here, Mel Goldberg, and Paul Waters. They were great teachers as well as superb surgeons. Dr. Hal Urschel forged a friendship with me just a few years after I returned to the Brigham. It seemed as if somebody had sent him. He was all optimism and encouragement, and we're honored to have Betsy here with us today. Tony LaRue is a respected longtime friend and mentor. Tony has served as our visiting scholar for the last 4 years. He and Gertzie have become dyed-in-the-wool Red Sox fans. When I came back to the Brigham in 1988, I was surrounded by greatness in cardiothoracic surgery. This picture was taken at the visiting professorship of Dr. Denton Cooley. 10 of the surgeons in this picture either had been or would go on to be presidents of the most prestigious surgical societies in the world. But the individual in my life who makes it all run, who gets everything done, and assures that everyone is taken care of is, of course, Mary Gillen. Mary and I have worked together for 21 years, and Mary, thank you for being you. These are our physician assistants, and they're committed professionals who deliver exemplary patient care. To all of them, I say thank you. Well, they say your partners are the most important people in your professional life. I'd like to acknowledge this group as my friends and colleagues that I hold in highest esteem. They are dedicated, focused academic surgeons who strive to make a difference and create new knowledge. 5 of them are full professors at Harvard, and the remainder are well on the way. I'd also like to say thank you to the residents and fellows that I've had the privilege to train over the last 26 years. As Pedro mentioned, this has been one of the most fulfilling parts of my career. I would now like to ask for your undivided attention. Please stay with me as I deliver a message today that I submit is vital to sustaining excellence in the practice and teaching of cardiothoracic surgery. Teaching trainees how to excel as surgeons is essential to our academic mission. Throughout history, great thinkers from all schools of thought have grappled with the concept of excellence. To my mind, clarity of purpose and focused attention represent the essence of excellence. Today, we will explore this concept in some depth. Excellence in surgery is under attack. Unprecedented levels of daily distraction erode our ability to identify and hold on to purpose and to focus our attention on that purpose. The threat to excellence is recognized in other fields where strong countermeasures are being taken. I propose that we must do the same. I will illustrate some of the elements of an action plan that we have found successful in our program. And then I will tell you a story of a surgeon who, through the power of his clarity of purpose and focused attention, exemplified excellence in his contributions to his chosen field of surgery. And he did so with meager resources and in the most unusual of circumstances. The dictionary defines excellence as a state of superiority or eminence, or we might say preeminence. However, these static descriptions miss an important nuance, that excellence is not a trait inherited by fortunate individuals. Rather, it must be achieved and maintained through sustained, purposeful, focused action. You might say it's performing a task consistently as close to the ideal as possible. More than 2,300 years ago, Aristotle defined excellence with reference to this active process. He said, "Excellence is never an accident. It is always the result of high intention, sincere effort, and intelligent execution." How do we break this down? The high intention recognized by Aristotle is not merely a spark that initially ignites the process. It must be clarified and sustained as a singular driving purpose throughout the endeavor. Furthermore, all of one's conscious attention must be exclusively and unrelentingly focused, the physical and intellectual activity required to fulfill that purpose. Indeed, all of these elements must coexist if excellence is to be the result. Maintaining and holding on to purpose, as well as gaining and holding the ability to focus, is becoming harder and more difficult in the information age. What is meant by the phrase clarity of purpose? Most importantly, it must be a singular purpose in the moment. I tell the residents that the secret to discover your purpose at any moment in time is to first close your eyes and then open them again and see what's directly in front of you. It may be a colleague, it may be a nurse with a question, it may be a patient, a family member, you name it. That's your purpose. And then that purpose needs your attention. Having identified your purpose in the moment, now focus your attention on it and then get it done. Here's the pyramid of purpose. Purpose is both the driving force and the direction. Layers of purpose can lead to a life of habitual excellence and sustained accomplishment. The sharp point of the pyramid is analogous to the narrow focus required for the greatest achievements. These layers of purpose are intertwined. One cannot exist without the other. The more singular and refined the purpose, the easier its fulfillment. Members of our association, dating back more than 100 years, have lived this paradigm and have made tremendous contributions to cardiothoracic surgery. Purpose and focus are closely interrelated, but subtly different. Once you have determined what your purpose is, your priority shifts to execution of a task, and for that you need focus. Focus involves excluding thoughts unrelated to the task at hand until that task is completed. Doug Silsby, author of the book The Mindful Coach, suggests that the inability to clear one's mind of unrelated thoughts is the primary obstacle to excellent performance. Focus relies on the ability to subjugate well-practiced repetitive tasks to the subconscious mind. This leaves the conscious mind unimpeded to be creative and to anticipate and address quickly any problems that may arise. We're not thinking about how to tie a knot or how to hold a needle, but instead the larger issues such as the overall conduct and direction of the procedure. Awareness of our physical surroundings is an essential component of focused attention. In the OR, the surgeon who keeps this awareness is often first to detect an issue of concern. But surgery, like golf, is a course in mind training. In paraphrasing the words of Aristotle, the 20th century philosopher William Duran has said, "We are what we repeatedly do." Excellence, then, is not an act, but a habit. Here's Tiger with a flawless golf swing, the product of endless practice, focused attention, the exclusion of all competitive thoughts, as a matter of fact, the exclusion of all thoughts, as he then relies upon his practiced ability, unimpeded, to shape this perfect shot. Tom Brady, excellence personified, the complete package, as reflected in his pyramid of purpose. As the New England Patriots quarterback, he set many NFL records for passing and is one of the best in football. Here, Tom Brady is throwing a pass. His purpose in this moment is to bring his team down the field by executing a series of effective plays. Purpose is what you're going to do. Focused attention is how you're going to get it done. Look at the expression on Tom Brady's face. He's totally focused. He has a general awareness of what's going on around him, of potential tacklers, what's downfield, and where his receivers are. However, his mind is clear of extraneous thoughts. He is never aware of the mechanics of the throw, but is aware of the logistics of the field, the position and movement of the defenders, and the motion of his receivers. Purpose and focus combined, producing extraordinary excellence. We all experience constant distractions from the information age: smartphones, emails, social media, unrelenting barrage of distractions. Meg Moore talked about it in the previous talk. There's no impediment to feeding your mind. It's the sheer availability of information. It's literally at our fingertips. What happens when we're distracted? We drop out. After the distraction resolves, we're stressed to catch up. It's like going to a movie and stepping out to buy some popcorn. When you step out, you drop out. When you come back, you have to ask, what happened when I was gone? And I don't think we fully recognize how often this happens all over the hospital, literally hundreds of times per day, as we drop out of a particular situation and then are stressed in the ability to get back into the same orientation. We're no longer insulated from outside distractions when we enter the hospital, as many of us were in the past. Distractions from within, from without. The shortened period of time that residents are physically in the hospital is eroding their ability to perform in an excellent fashion. A destabilization of our workplace culture is occurring. When many of us were training, the surgical culture was inherent to being in the hospital. That's no longer the case. These factors are affecting each one of us as well. We have to recognize what's happening and take action. What is the impact of all this distraction on medical and surgical practice? You can see listed here just some of the factors that are impacted by the use of smartphones while in the hospital. The literature is accumulating and is overwhelmingly negative. You may note the last point on this slide. Malpractice cases are lost these days because of smartphone distractions documented by subpoenaed phone records. Some of you may recall this publication that was cited in the New York Times. The article received a significant amount of attention in the lay press. In 2010, Smith and colleagues surveyed 439 perfusionists about their smartphone use during cardiopulmonary bypass. 49% admitted to texting while on bypass, 21% to emailing, and 15% to surfing the net. Now, only 7% recognized a negative impact on the case from their own behavior, but 34% recognized it as causing a negative impact when observed in coworkers. And these data are 4 years old. This is real. It's no joke. Surgical excellence is at stake. So what can we learn from the ways that other industries have responded to the challenges of distraction? Piloting an airplane is a situation where distraction and multitasking can have catastrophic consequences. In 1979, NASA identified human error during takeoffs and landings as the primary cause of air transport accidents. The resulting policy, the sterile cockpit, forbids all unrelated discussion between pilots and co-pilots during takeoffs and landings. NASA emphasized the importance of codifying expectations, establishing strategies for routine reporting, and management of errors. The sterile cockpit is a classic example of what it takes to shut out competing information during critical task execution. Bounded deferral is a policy initiated in the computer science industry, which electronically defers digital notifications in the workplace to a designated or bounded time frame. The practice has been shown to create a calmer, less disruptive, it's noted to reduce stress, improve the quality of work, decrease error rates, and increase productivity. The concept of mindfulness dates back to ancient Buddhist teachings when meditation was regarded as the doorway to enlightenment. There was a rebirth of mindfulness concept in the 60s and 70s when psychologists and other practitioners began to explore the benefits of stress reduction through meditation. Dr. Jon Kabat-Zinn, a leader in the field of mindfulness-based cognitive therapy, defines mindfulness as paying attention in a particular way, on purpose, in the present moment, and non-judgmentally. Multiple studies showed that subjects who practice mindfulness increased their ability to focus and improve their performance. Phrases like being in the zone and automatic, effortless attention to task or flow began to appear in psychology, sports, and business literature in the late 90s. Our society and our culture see and feel the impact of repetitive extraneous thoughts caused by relentless distractions and are finding relief through the practice of mindfulness. Well, what should we do in CT surgery? Should we teach mindfulness as many successful coaches do? Well, the problem seems, frankly, overwhelming. How are we to deal with this onslaught? I would propose to restrict distractions that could be safely reduced. For example, we have a smartphone policy. We've created a system of focal points to command the attention of our residents throughout their time on the service. What are these focal points? They are tasks or times that require the attention of individual team members. They act to transmit information and draw attention to the activities most conducive to learning and to the enhancement of care delivery to patients. They are explicit and repetitive communications of codified expectations. They serve as constant reminders of what is expected each day by each member of the team. Through all of the distractions that are present in this age, we need to continuously instruct our residents in a repeated fashion as to what it is they need to focus on while they're in the hospital. And we've created a system to do this. It's almost on autopilot. We should ask ourselves this question: why does anybody need to have a cell phone in the operating room during a case? Our policy is to the right. The goal is to reduce the use of cell phones for personal calls, to eliminate them from the operating room, and instead to encourage direct and closed-loop communications, such that the information transfer is verified. You can ask your hospital administration to support such a policy for all the OR staff. The Association of Operating Room Nurses and the American College of Surgeons both support such a policy, but you'll need to take action. This is the whiteboard on the wall in our operating room. The resident is required to fill it out before each case. On the left side of the whiteboard, you can see the history, pertinent lab and radiologic data. To the right, the residents write the 10 steps of the operation from their preparation the night before. The exercise provides a focal point, a need for them to focus and a need to prepare. And it provides an excellent opportunity to teach. We reinforce and teach essential skills like communication, how to organize a patient presentation, and the template for patient presentations is displayed in the clinic. And each resident is given a pocket-sized version of these expectations for daily use and future reference. Now, this is a foundational document. It codifies our core values and expectations for the conduct of the thoracic surgery service. The residents call it the pledge. Every week at our QA meeting, a resident stands up in front of the entire group and reads this document out loud. It's a method used in the context of providing 5-star service. I first saw it done in a California hotel in 2003. With the time change, I was up early. It was about 4 o'clock in the morning, and I saw a member of the hotel staff read the list of expectations to the entire hotel staff in the lobby as they were reading along on their own copies. When I inquired of the manager what I'd seen, he explained that by doing this, they were creating a stable work culture in the hotel. Having the resident staff recite this document weekly has had a very positive impact on the efficiency and quality of patient care that is delivered on the service. It's a superb teaching tool as well. We also use the fulfillment of these expectations in making objective resident evaluations. Here are some clips of Dr. Jeff Vallada, our chief resident, reading this document last week.
Good morning. Priority setting. Each individual on the thoracic team understands that patients and their needs are the top priority 24/7 when a team member is on duty in the hospital or on call. All tasks are to be prioritized in order of importance for completion. Rounds. The service will round twice a day, including weekends, and rounds will include an available pod nurse. A thorough and comprehensive person-to-person sign-out between team residents will occur twice a day with shift change. Additionally, multidisciplinary rounds will occur daily between junior residents and physician assistants face-to-face. Documentation. It is expected that all adverse events, procedures, transfers, all communications with attendings after hours, or other unusual occurrences will be documented in the chart at the time of occurrence. Daily progress notes are required on all patients, no exceptions. Communications. All adverse events, procedures, transfers to TICU and ICU, emergent scans, vasoactive drips, unplanned discharges, and unexpected admissions will be communicated to and discussed with the attending staff. The Director of TICU and Chief Residents will conduct comprehensive face-to-face meetings before 7:30 a.m. and the Director of TICU and Service App Fellow and/or On-Call Fellow will meet daily at 4 p.m. Professionalism. The Thoracic Surgical Resident Team values professionalism as being of utmost importance in the career development of the resident staff. Residents and fellows are expected to wear white coats at all times on the ward. It is expected that all team members will remain polite and professional at all times. Cell phone use. The use of cell phones for personal calls and texts while in patient areas is strongly discouraged. Cell phone use in the operating room or during rounds and conferences is restricted to emergency calls only. Residents should sign out during operative procedures. Emergency reports to the OR should be done in person by resident staff. Closed-loop communication standards will be followed. The verbal communication of patient status and information is always preferred. Cell phones will be on vibrate or silent mode while in the hospital.
Dr. Vallada, what do the residents think of the pledge?
I think the residents find it extremely valuable, especially for the new residents. They can help focus their daily duties, and I will definitely take the pledge with me.
I'd now like to tell you a story of Everett Sugarbaker. You can see on the face of this gentleman a certain intensity and a certain intention. All he's doing at that moment is reading that particular manuscript. His life was one of high intention. He had a clarity of purpose that was, well, quite amazing. His ability to focus his attention despite an avalanche of continuous distraction was phenomenal. His pyramid of purpose had a very sharp point. He grew up in the midst of the Great Depression and worked his way through college and medical school. His father, Evert, and his mother, Anna, were Dutch immigrants. They came to this country with nothing. He found his life's purpose in medicine. Here he is as a first-year medical student at Cornell in the gross anatomy lab. And as you can see, the attire in the lab was, quite different in that day than it is now. Let's follow the development of his pyramid of purpose as his career progresses. Here he is next to my grandfather on his graduation day from Cornell. A happy day indeed. He did an internship at the Henry Ford Hospital in Detroit because it paid $125 a month, and that salary allowed he and my mom to get married. Here is now the building of his foundation of purpose. The layers continue to be laid down. Then it was on to the Memorial Hospital in New York City, which was the first cancer hospital in the United States. He spent from 1935 to 1939 at this prestigious institution founded by James Ewing and financed by John D. Rockefeller. It was the academic center for surgeons interested in cancer. It was established for the treatment of cancer and allied diseases. His time there was marked by intense academic productivity. He spent hundreds of hours in the record room and published many seminal papers. Here he is seen with his fellow residents in the Memorial Hospital. Many of these individuals went on to pioneer cancer surgery all over the United States. They founded the James Ewing Society, that later became the Society of Surgical Oncology. He left Memorial to become appointed Chief of Surgery at the National Cancer Institute in Baltimore. However, that clinical program became a casualty of the Great Depression. Where did he go? As a lifelong East Coaster, he took a position at the newly built Ellis Fischel State Cancer Hospital in Columbia, Missouri. Columbia was a small town on the edge of the Ozarks. This was at a time when the town was characterized by late 19th century culture. He was the first surgical oncologist west of the Mississippi, according to a recently published book on the history of Missouri medicine. He was told by his associates in New York that this was a primitive place that would not allow him to ever do large or complex surgical cases due to the lack of support. They pronounced that his academic career was definitely over. Here's an old postcard of the Ellis Fischel State Cancer Hospital, established by the Missouri State Cancer Commission to serve indigent cancer patients. He came as a young chief of staff and a chief of surgery, and basically built the clinical infrastructure from the ground up. He had a knack for recruiting excellent individuals such as Dr. Lauren Ackerman, seen here, who would go on to write the first textbook of surgical pathology, and Dr. Juan Delgado, a radiation oncologist who trained with Marie and Pierre Curie, and who was a pioneer as well. The Ellis Fischel became a focus for the surgical training of residents and fellows from around the country. Together with his staff, they published over 100 papers during the next 10 years. He built teams and hospital infrastructure and established a capable blood bank. So what about performing big and complex surgery? Was it, as they predicted, impossible? I think this paper demonstrates that he took his superb surgical training with him to this primitive setting. This is illustrated by the figures seen here from the pioneering and seminal paper on the technique of hemipelvectomy. Building his layers of purpose. With a growing family, he moved his practice 35 miles south to Jefferson City and established the Sugarbaker Tumor Clinic. Jefferson City is located on the Missouri River on the Ozark Plateau, and it's on the Lewis and Clark Trail. He established the Sugarbaker Tumor Clinic with its own radiation therapy machine, radiology equipment, as well as minor surgery procedure rooms. The patients came from all over the Ozark Hills and the surrounding states. The waiting room was packed on clinic days, and it was standing room only on the front porch. As a kid, I loved to be there around on clinic days. There was so much energy. This is the original sign that hung on the white column on the front of the clinic the day it opened. It says the clinic was established for the treatment of cancer and allied diseases. Well, he was troubled, as other surgical oncologists were, at the number of times he was unable to perform a low anterior resection, which could spare the patient a permanent colostomy. The challenges set his creative mind to work. So he designed what he called the gadget. He worked with an old German machinist who had a one-man shop located near the train station. This was a rectal anastomotic instrument which was commercialized by Sklar Surgical Instruments Company. You can see it here in place. With the use of the gadget, he was able to save the lower sphincter in a large number of patients. You may note here that this particular design with the alternating pin locking mechanism is similar to the design used in the EEA stapler, which came much later. The US patent was issued in 1953, continuing to build his layers of purpose. His love of tumor biology and his quest for answers, particularly regarding the mechanisms behind metastases, motivated him to build this laboratory in the garage that was situated right next to our home. In this laboratory, with the technical assistance of his sons and daughters, he maintained a rat colony. He kept white Wistar rats, which were flown in to Jefferson City from the Charles River Laboratories in Boston every month. He developed and kept 3 tumor lines going for experimentation by retransplanting the cells every 2 weeks into fresh rats. He was very interested in why certain tumors were distributed from particular areas, were distributed from particular tumors to different parts of the body. So he freehand injected emulsified tumor cells from 3 different tumor lines into the left ventricle of normal rats. He then carefully autopsied the rats, as you see in this slide, and described the different metastatic patterns. Here are the results. This is the organ distribution of gross metastases found in 46 rats who underwent a freehand left ventricular puncture with emulsified tumor cells. What he established was that these 3 tumors each had separate metastatic patterns. This work disproved the Halstedian mechanical theory of metastatic spread. And he published this paper in Cancer, the most prestigious cancer journal of its time. He published it from the Sugarbaker Tumor Clinic in Jefferson City, Missouri, from a laboratory located in the garage. This paper was cited multiple times this last year, and this work is recognized as the foundational contribution to the understanding of metastatic disease, the so-called seed soil theory of metastases. The story that I've told you is a perfect example of a pyramid of purpose that, when combined with focused attention, produces a career marked by excellence and accomplishment. I'm reminded of my father's words, "David, wherever you go, it's 90% you and 10% where you are." Clarity of purpose and focused attention are indeed the essence of excellence. Excellence in our specialty now and in the future is in our hands. My message today is that excellence in the practice of surgery is threatened. The ability to formulate a clear purpose and hold focused attention is becoming more difficult. Electronic distractions are ever increasing and are having a negative impact on resident training. These distractions make the conduct of an orderly surgical service more difficult. We can take countermeasures. You have seen and heard some of the ways that we can effectively begin to do this. Using explicit, repetitive communications of codified expectations in our residents, we can enhance resident training and improve patient care. These strategies help to stabilize our workplace cultures. The portfolio of documents, by the way, that I've shown you today can be downloaded from the AATS website. I'm sure that many of you will make changes in them to fit your own institution. But the methodology, in our experience, is very effective in helping the residents stay focused on their responsibilities and in their efforts to learn. And their response has been very positive. As many of you know, it will soon be my privilege to join the staff at Baylor St. Luke's Medical Center in Houston. I'm excited to embark on the next phase of my career. I'd like to conclude my remarks with a parable. There was an ambitious young surgeon who wanted to make progress against human disease through his own career. He approached a large wall made of black granite that had the label "human disease." He picked up his pickaxe and began to swing, next to many other young surgeons who were doing the same. However, he was discouraged that despite his effort, there was no dust, no progress. He then became aware of an older surgeon, his soon-to-be mentor, sitting nearby, and queried him as to how to make progress. The old surgeon took the pick and turned it around to the sharper side. He then took out a grinding wheel and sharpened it to a fine point. He said to the young surgeon, "Take this and try it again." With only a few swings, the young surgeon saw dust and began to make progress. Well, the moral of the story is, the ambitious young surgeon had purpose. He wanted to make progress against human disease. He was aware of the older surgeon when others weren't. With mentoring, he further defined his purpose, focused his efforts, and began to make rapid progress. I'd like to thank you for the privilege of serving the American Association for Thoracic Surgery as your 94th president. And thank you for your kind and focused attention this morning. Thank you very much.